to AIOS, and thank you, Chairman. Coming to phaotrabeculectomy, we need to do it when glaucoma needs surgery and there is cataract, like in angle closure, open angle which is not controlled, or visual field progression is there, or a cataract needing intervention and the patient also has glaucoma. Why do we do a phaotrab and not a trab alone? It's because it obviously is for the second surgery, which may compromise the filtering surgery, and the AC shallows further, especially if it's an angle closure. The chances of cataract to increase is almost threefold in the following time after trab, and a functioning trab may fail. And also patients prefer a single surgery, and also cost-benefit analysis ratio makes us feel that we should do for a phaotrab. The success lies not only in the surgical steps, but also in the preoperative and the postoperative assessment. In the preoperative, we should see whether there is any blepharitis, any scarring, whether there is any scleral thinning, how advanced is the glaucoma. And also, we should stop the prostaglandin analogs 3 weeks prior to the surgery. Try to, if possible, if it is the first eye which is being operated, try to shift them to oral acetylzolamide for a week or so, half TDS. Stop pilocarpine, and also start lotipred for the 2 weeks prior so that one has a less inflamed eye. Stop antiplatelets, of course, and if need be, give mannitol during the surgery. Surgical dilemmas are many, and hence we try to a brittle suture can sometimes injure the superior rectus and superior oblique, so tonal stay suture is better. The fornix-based incision is better because it is easier to make, better visualization of the limbus. It is compatible with MMC usage, and the suturing is easier. And it is also done, the reason why limbal one is not good is because it may cause a ring of steel, although it depends on every surgeon's hands, and this may lead to an overhanging bleb because of the scarring which is there. The scleral flap may be triangular or rectangular, it depends on the surgeon's hand again. I am comfortable with both, but I now prefer to do a rectangular. And it is better to use the side port knife and then dissect it with a crescent blade. And it is better to use an atraumatic Pierce-Hoskins forceps. And the scleral flap should not go right up to the tip and should at least leave 1 millimeter at the edge near the limbus, so that the flow of the aqueous once the surgery is done is posterior. Also, one should change the direction of the thing when it enters the cornea, and and if by chance you do have a amputation of the flap, you can always suture there. And coming to the rectangular one, I prefer to do this, a 4 mm and a 4 mm behind. Mitomycin C, it should be in a low dose for a longer time, say maybe 2 to 3 minutes. And when you are applying it, you do not touch the edge of the conjunctiva. so that there is the conjunctiva healing is not compromised. A good AC wash thoroughly through the conjunctival sac is a very a good thing to do, and change your instruments thereafter. And the sclerotomy punch, one should leave the same side, like if you have a 4 mm, leave 1.5, 1.5 on each side, so that you have a good flow and it's done well. And the broad-based iridectomy prevents iris incarceration and ostium into the blockage, and one should ensure that it can be seen properly, and the base of the iridectomy should be wider than the sclerostomy opening. When we are doing the sutures, the reusable suture is very easy to do. One should not have the tip exposed, so one can follow this way to do it. And when we are tying the half knot on the releasable suture, it should be a slanting suture, so that it allows a drainage rather than be a watertight suture. Then coming to meticulous conjunctival suturing. If it is limbal, then you do it in 2 layers. When it is conics based, you do it in such a manner that you put 2 mattress sutures on the side and bury the knot. And after that, we can check whether it is sealed well or not, and through the side port check that the phlegm is forming and there is no leakage. You can also use the fluorescent strip to check that there is no leakage. And the Moorfield system of surgery, safe system surgery, should be followed when you are doing a phacotrap. Post-op care, 8 to 12 weeks of anti-inflammatory steroids as well as NSAID should be started after a few weeks. Cycloplegics is a must, atropine for 3 weeks or more if needed. Lubricants, assess the bleb as needed by AT, and bleb vascularity by SLE and by ASOCT can be judged. We want a bleb which is going as far as this bed of lilies and is shallow. And thank you for patient hearing.